Multiple pregnancy is defined as the presence of more than one fetus in the uterus during pregnancy, the commonest one being twin pregnancy. Monozygous twinning rates are constant throughout the world, occurring in 3 to 5 per 1,000 births. Dizygous twinning rates vary widely and are affected by maternal age, race, nutrition, and geographical location. Due to the increasing prevalence of IVF and ICSI pregnancies, the numbers of twin pregnancies has continued to rise. Mortality and morbidity. Perinatal mortality rates are higher for multiple pregnancies compared with the singleton pregnancies. The risks of producing a child with cerebral palsy are 8 times greater in twins and 47 times greater in triplets compared with singleton pregnancies. The risk of perinatal death and long-term neurological sequelae is largely influenced by the increased rate of pregnancy complications, particularly preterm delivery and low birth weight. Zygosity versus chorionicity and amnionicity. It is extremely important to understand the difference between zygosity and chorionicity because zygosity refers to the genetic makeup of twins, whereas chorionicity refers to the placentation of twins. Amnionicity refers to the relation of the amniotic membranes between the twins. Types of twin pregnancy. Twinning occurs in mainly 2 ways, monozygotic and dizygotic. When a single zygote splits into 2 equal zygotes, they share the same genetic material, and these are called monozygotic twins or identical twins. When cleavage occurs by 3rd day, it results in fetuses bearing separate amnions and chorions. Cleavage occurring between 4th to 8th day results in fetuses having separate amnions but a common chorion. Cleavage occurring 8th to 13th day results in fetuses sharing common amnion and chorion. In later division, result in conjoined twins where there is union between fetuses. Monozygotic twins are always of the same sex. When 2 different zygotes are formed by simultaneous fertilization of 2 eggs by 2 sperm, they will be made up of different genetic material and are called dizygotic twins or non-identical twins. When 2 ova are fertilized, 2 chorions and 2 amnions may be formed. Dizygotic twins could be of same or different sexes. These are the factors affecting dizygotic twinning. More common in dark races. Maternal family history of twins or multiple pregnancy. Increased parity. Increased maternal age. Higher fertility. Increasing use of ovulation induction drugs in assisted reproductive techniques. And in vitro fertilization, IVF. Complications and risk of multiple pregnancy may happen to either the mother or the fetus. Maternal complications and risk can be classified as antenatal, intrapartum, and postpartum. Antenatal complications include excessive nausea, vomiting, or hyperemesis gravidarum. Pressure symptoms such as edema, hemorrhoids, varicose veins, miscarriage, anemia, acute or chronic polyhydramnios, pregnancy-induced hypertension, antepartum hemorrhage, abruptio placenta, preterm labor, and/or premature rupture of membrane. Intrapartum complications include malpresentation, cord prolapse, and/or higher incidence of operative or assisted delivery leading to increased hemorrhage and infection. And finally, postpartum complications include postpartum hemorrhage and/or anemia. Complications and risks fetus may face are spontaneous abortions, single fetal demise, prematurity, intrauterine growth restriction, congenital anomalies, and/or increased perinatal mortality, which is 2 times greater in second twin due to growth restriction, malpresentation, or assisted deliveries. Complications and risks specific to monochorionic twins include twin-to-twin transfusion syndrome, twin reversed arterial perfusion syndrome, and/or cord entanglement locked twins. Clinical features of multiple pregnancy may include the following. 1. History of taking ovulation induction drugs. 2. Exaggerated nausea, vomiting, or hyperemesis gravidarum. 3. Exaggerated breathlessness. 4. Pressure symptoms such as edema or varicosities. 5. Features of complications of multiple pregnancy such as threatened or actual miscarriage, pregnancy-induced hypertension, anemia, antepartum hemorrhage, preterm labor, or premature rupture of membranes. Examination of suspected multiple pregnancy may yield the following findings. 1. Uterus larger than expected date of delivery. 2. Multiple fetal poles. 3. 2 simultaneous foci of fetal heart rates that vary by 10 beats. 4. Features of other associated complications of multiple pregnancy. Ultrasound is the most reliable method to determine the presence of multiple pregnancy. Early ultrasound assessment is crucial in the management of multiple pregnancy, especially for 1. Diagnosis of multiple pregnancy. 2. Dating the accurate estimation of gestational age, with measurement of largest baby used to estimate gestation age. 3. An assessment of chorionicity. Assessment of chorionicity can be performed using the lambda sign. The V-shaped extension of placenta tissue into the base of the intertwin membrane is referred to as the lambda, and this determines dichorionicity. T-shaped extension of the intertwin membrane or the absence of the lambda determines monochorionicity. The number of placental mass, discordant fetal sex, and membrane thickness are also used to determine chorionicity. During antenatal screening, it is essential to assign nomenclature to fetus, example, upper or lower, left or right, to ensure consistency of management throughout pregnancy. Screen for aneuploidy using nuchal translucency. Antenatal screening can also be used in prediction for twin-to-twin transfusion syndrome. Women expecting monochorionic twins should be seen and scanned once every 2 to 3 weeks from 16 weeks of gestation until delivery. Between 16 and 24 weeks of gestation, the main purpose is to detect twin-to-twin transfusion syndrome. Between 18 to 20 weeks, fetal anomaly scan should be undertaken. Conduct serial growth scans to look for intrauterine growth restriction and growth discrepancy. Fetal weight discordance may be estimated using 2 or more biometric parameters at each ultrasound scan from 20 weeks every 28 days. A growth discrepancy of more than 25% between fetuses is an indicator for intrauterine growth restriction. Doppler assessment and cardiotochogram. In monochorionic twins, if one twin is smaller, assessment of fetal circulation and well-being should be performed weekly to bi-weekly. Management of complications in multiple pregnancy. Look for signs of anemia so that early supplementation with iron and folic acid may be prescribed. Managing hypertensive disorder in pregnancy. Early detection is key for the management of hypertensive disorder in pregnancy, especially in cases of multiple pregnancy. The advice is to take 150 milligrams of aspirin daily from second trimester if any of the following risk factors are found. Preterm birth, or birth under 37 weeks gestation, occurs in more than 50% of multiple pregnancies. Preterm pre-labor rupture of the membranes also occurs more frequently. Maternal risks of pre-labor rupture of membranes include hospitalization, use of tocolytic drugs including its side effects, and psychological sequelae. The risk is higher for monochorionic compared to dichorionic twins. Intrauterine growth restriction. A fetus is considered SGA if the abdominal circumference or effective fetal weight are below the 10th percentile. Fetal risks are similar to singletons with growth restriction, such as intrauterine fetal demise and neurological morbidity. The definition of growth discordance is when the weight difference between fetuses is 25% or more. It is calculated using the formula estimated fetal weight of larger fetus minus estimated fetal weight of smaller fetus divided by the estimated fetal weight of larger fetus. Growth discordancy increases the risk for adverse perinatal outcomes, and the possibility of twin-to-twin transfusion syndrome needs to be ruled out. Classification of growth restriction or growth discordance can be based on Doppler characteristics of the umbilical artery in addition to the gestational age at first presentation. The goal of management is to prevent intrauterine demise and long-term neurologic damage. There is an increased incidence of structural and chromosomal abnormalities more evidently in monochorionic twins. Common abnormalities include neural tube defects, facial clefts, gastrointestinal defects, anterior abdominal wall defect, and cardiac anomalies. Management is complicated with medical and ethical dilemma and includes conservative, selective feticide, or termination of whole pregnancy. Early demise is termed the vanishing twin and occurs in 25% of cases. Demise beyond 12 weeks puts the remaining twin at risk of poorer outcome. Management is conservative with serial ultrasound scans. Risks in all multiple pregnancies includes miscarriage and severe preterm birth. Risk specific to monochorionic twins includes co-twin demise and neurological abnormality. Management of single fetal death is conservative and comprises of MCA Doppler studies to exclude fetal anemia associated with twin-to-twin transfusion syndrome. A thorough neurodevelopment assessment and follow-up is necessary after birth. Prognosis is usually determined by chorionicity and gestation age. Twin-to-twin transfusion syndrome, TTTS, and twin reversed arterial perfusion sequence, TRAP, TRAP, are the two most well-recognized complications of the unique vascular architecture in the monochorionic placenta. Twin-to-twin transfusion syndrome is unique to monochorionic pregnancies and is caused by imbalanced net flow of blood transfused across arteriovenous anastomosis. This results in donor twin having conditions such as hypovolemia, oliguria, and olighydramnios, and recipient twin with conditions such as hypovolemia, polyuria and polyhydramnios, fluid overload. Diagnosis is made via ultrasound monitoring. The main criterion for diagnosis is the combination of polyhydramnios in one sac and oligohydramnios in the other. Based on these features, the Quintero staging is useful to describe and understand the spectrum of the twin-to-twin transfusion syndrome. In stage 1, oligopolyhydramnios sequence with visible fetal bladder in the donor twin can be detected. In stage 2, fetal bladder is not visible in donor twin. In stage 3, abnormal Doppler studies in either twin. In stage 4, fetal hydrops are detected in either twin. And in stage 5, death of one or both twins occurs. Untreated twin-to-twin transfusion syndrome bear a mortality of almost 100%. Morbidity of survivals includes cerebral and cardiac sequelae owing to chronic hemodynamic imbalance in utero. Treatment options for twin-to-twin transfusion syndrome include laser ablation, amnioreduction, serial amnioreduction, selective feticide, or termination of pregnancy. Twin-reversed arterial perfusion sequence, also termed a cardiac twinning, is a rare complication affecting about 5% of monochorionic pregnancies. Twin-reversed arterial perfusion sequence is characterized by an acardiac perfused twin, which receives its blood supply parasitically via a large arterio-arterial anastomosis from a normal pump co-twin. This results in absent or rudimentary development of the head, heart, and upper limb structures. The high perinatal mortality of the normal pump twin is over 50% and is mainly due to high output congestive heart failure and hydrops. Otherwise, it is due to prematurity induced by polyhydramnios. Assessment and management should be undertaken in tertiary fetal medicine services. Definitive treatment of twin-reversed arterial perfusion sequence is through the separation of the two fetal cardiovascular circulations, either by bipolar dithermy to occlude the cord or by interstitial laser or monopolar dithermy of a central vessel of the acardiac twin. Twin anemic polycythemic sequence. This condition is unique to monochorionic twins and refers to the discordance in hemoglobin between a monochorionic pair in the absence of amniotic fluid discordance. The pathophysiology is again due to an imbalance in intertwin transfusion, resulting in hemoglobin discordance. Diagnosis is made via MCA Dopplers, suggesting anemia and polycythemia respectively. Anemia results in hydrops and intrauterine death of donor, while polycythemia causes cardiac failure and death in the recipient. Twin anemic polycythemic sequence can occur spontaneously or after incomplete laser ablation for twin-to-twin transfusion syndrome. Management includes elective delivery, cord occlusion, or fetoscopic laser. Cord entanglement is unique to monochorionic twins and its incidence varies from 42% to 100%. This may contribute towards intrauterine death. Therapy to reduce incidence of cord entanglement includes elective preterm delivery, oral sulindac therapy to reduce fetal urine production, liquor volume, and fetal movement. Timing of delivery. At 37 weeks, offer planned birth for uncomplicated dichorionic diamniotic twin pregnancy. Offer planned birth as follows, after a course of antenatal corticosteroids has been considered. At 36 weeks, for women with an uncomplicated monochorionic diamniotic twin pregnancy. Between 32 and 33 weeks, for women with an uncomplicated monochorionic monoamniotic twin pregnancy. And 35 weeks, for women with an uncomplicated trichorionic triamniotic or dichorionic triamniotic triplet pregnancy. Offer an individual assessment to determine the timing of planned birth in women with any of the following: a complicated twin or triplet pregnancy, a monochorionic triamniotic triplet pregnancy, and lastly, a triplet pregnancy that involves a shared amnion. Based on the presentation of first twin and various positions of the twins, different modes of delivery are recommended. For a vertex-to-vertex presentation, vaginal delivery is recommended. For vertex-to-breech or transverse lie presentation, optimal mode is unknown. However, literature supports both vaginal delivery and cesarean section. Management of second twin includes external cephalic version or internal podolytic version and breech delivery. Where the leading twin is non-cephalic, cesarean section is recommended. For very low birth weight infants, less than 1,500 grams, optimal mode is unknown, but generally cesarean section is recommended to reduce fetal trauma. However, there is little evidence on any differences in perinatal outcomes. For monochorionic or monoamniotic twin pregnancy, cesarean section is recommended to prevent intrapartum cord complications. In cases with triplet or higher order pregnancies, optimal mode is unknown. Generally, cesarean section is recommended due to difficulties in monitoring. These are the important points to note. Determine the presentation of the leading twin. Conduct a placental localization to determine and plan the mode of delivery. ECV is contraindicated if first twin is in breech presentation. Continuous CTG monitoring of both twins throughout labor is necessary. Second stage of labor should be done in operating theatre with anesthetist and paediatrician on standby. Confirm position of second twin after the delivery of first twin by ultrasound scan, as there is a 20% risk of change in presentation of second twin. If second twin is cephalic and there is no descent of head despite syntocinon, resort to cesarean section, as there will be no place for high forceps or vacuum. If second twin is breech, consider breech extraction if obstetrician is experienced. Otherwise, conduct a cesarean section. If second twin remains in transverse lie, consider internal pedalic version with breech extraction or external cephalic version if membranes are intact and obstetrician is experienced. Otherwise, conduct a cesarean section. All precautions should be taken to prevent postpartum hemorrhage, as there is risk of atonic postpartum hemorrhage. It is especially important to take note of the following during puerperium for multiple pregnancies. 1. Observe for postpartum hemorrhage. 2. Treatment of anemia. 3. Management of lactation and breastfeeding. 4. Psychological support. 5. Treatment of neonatal problems. 6. Family planning advice. Thank you for watching this video. This video is presented by Yong Lu Lin School of Medicine's Department of Obstetrics and Gynaecology. For more videos like this, head on to the National University of Singapore's website.